الو الو دكتور سنان. الو سنان تسمعني؟
Good evening. Can you hear me now? I think it's okay. Okay, good evening, everyone. Today we will talk about the basic principle of MRI, how to manage the MRI, what we need from the technician, and what we gain from as a musculoskeletal system. Today we will talk about the basic principle, and later we will have uh, the two lectures about spine MRI and another two lectures about the knee MRI. I hope you will enjoy it. If anyone has a technical issue, please contact me with the chat box. Hope you to enjoy that. And then we will have your questions and shared talks. Okay. Is next, yeah, okay. So the objective of this study is whether we need an acceptable interpretation for MRI images. We need to have a good interpreting, and with good interpreting, we need to have a solid understanding of each basic principle of MRI. What are the T1 and what is the T2 image, and what is the spin and the stir. We will talk about this later. And describing the terminology used in the practice. These are the main objectives. Okay, so what makes a good image? Before we need an MRI, we have to look for the MRI if it is a good image or not. Actually, there are three things we need from the MRI to be a good image. First of all is lack of motion. And second is that signal and resolution. These are 2 points separately discussed. And we have a tissue contrast, whether the tissue is contrasted according to the T1 and T2. Okay, so what is a lack of motion? Motion is the greatest enemy. Cardiac motion, or maybe from the bowel peristalsis, respiratory motion. From our concern that discomfort regarding the musculoskeletal during supine position, the patient cannot have maintained about 40 minutes in supine position. So that's why the patient maybe got frustrated, as you see in this picture for the knee MRI in sagittal view, looks like a wave of water. So any movement will ruin the entire image. And the technician must support a pillow under the knee if you have a knee MRI, or a pillow below his or her head, and under the knee in this situation to comfort the back, because stretching on the sciatic nerve. Any restraints like a foam rubber or belt. Music on the room. Actually, most of the technician does not support a music in the room. Sometimes something very noisy MRI coil. That's why they makes the patient may get frustrated, especially when those who has claustrophobia, you know, all the patients, they are get afraid from. So oral sedation may be added as well. If you see in this picture, a sagittal view of the MRI of the knee, you can see this is a signal intensity on the posterior horn of the medial meniscus, whether it is a tear or there is a signal intensity due to this wavy movement of the due to movement of the knee during the MRI technique. Okay, so this lack of motion must be supported well with the MRI technician. Okay, so what is signal and resolution? Signal is the most important amount of information from the image. You can see signaling when it is increased, the resolution will decrease. I'm marked here in the A picture, which is above and below. This is the same knee, but you can see here a marked image noise and poor delineation of the anatomic structure. This is used in a full body coil MRI. While a knee-specific coil MRI will see that the higher resolution with the low signal. And that's why the slice of the thickness are decreased, minimum slice, minimum field of view, and increase of the image matrix. These are also regarding to the technician. So you don't accept the first one and you have to accept this one because it's very obvious to us regarding the noise, lesser noise, and the specific knee coil that depiction with anatomical structures. Okay, so this is regarding the signal, but resolution is here the ability to distinguish any small objects. It's critical in most of our concern in the musculoskeletal applications. The MRI may every attempt should be made to use the smallest coil as possible. For example, those in the in advanced center, they use a hand coil or a shoulder coil as this one. You can see here this picture with the axial MRI image that shows a well demarcated of the tissue, the labrum, and the synovial fluid, and within there is a loose body. Okay, this is called a resolution. So CT image is based on the X-ray attenuation properties of the tissue. This is regards the tissue reaction. And whereas the soft tissue contrast in MRI is related to difference in proton resonance within the tissue. The proton within the fat resonates differently than the proton in the fluid, and then changing the image of parameter of the MRI console that differences in tissue specific properties. This is called weighting the image. All these talks, we are talking about weighting the image. There are two types of weighting: a spin echo, fast spin, gradient, and stir. We'll talk about each later. You can see that the spin echo is either a T1 and T2. So regarding T1 and T2, you have here the strength in anatomical detail, the fat, meniscal pathology, and if you added an enhancement by gadolinium, and marrow pathology are all obvious in T1, and also in T2, but a well detection of the fluid that may contain any pathologic process. The fast spin echo usually fast spin echo usually fast spin echo usually in T2, and it gives us more detail in anatomy, and the contrast obtained from a shorter image time, excellent detection of bone marrow pathology, and it is a good patient for the metal hardware, especially when to reducing the susceptibility of the patient. Gradient echo, we have we want to ask if there is any fibrocartilage like a meniscus or a labrum, if there is a loose bodies, a 3D image study, or there is a highly susceptibility for effects. We have many weaknesses in there, but we will discuss more about this strength. So the stir also, this is called a short toe inversion recovery, which means that only the marrow and the soft tissue pathology are obvious here and shouldn't be used with the godalinum. Now, we talk about the signal intensity, why T1 and T2. What are the differences between them? Simply, when you see the fat in T1, it's a high signal intensity, while it is lower in T2. So the upward, the up arrow, when we go up or we go higher signal intensity, which is comparable to that of the muscle, because both in T1 and T2, the muscle is iso intensity. Okay, so when we see a higher signal intensity than the muscle, a higher but not that on T2. So the fluid is lower in T1 but very bright in T2 than that of the muscle. And the other tissues are in between. And we will see that later. Look at the air, both of them, there is a low signal intensity in T1 and T2. So you need only these two, fat and the fluid. The other are in containing, whether there is a containing of a fluid or containing fat, the other tissue. So what about T1 image? In T1 image is most useful for delineating the anatomic place, marrow architecture, fat content within masses, and subacute hemorrhage. As a fat, and you can see here, a signal intensity is low in T1, and the muscle is iso intensity. With that of the bone marrow, look at the cortical bone and the medullary cavity. The medullary cavity, as it with its blood and fatty tissue, it sometimes looks lower signal intensity than that of the muscle. You can see here, this is the humerus, midshaft of the humerus. It shows an axial view with a fatty tissue like that of the subcutaneous, well demarcated between the triceps muscle and the biceps. When using an enhancement, there is no intravenous enhancement inside that of the tissue. Look here in the level B or the picture B. You can see here a well demarcated also in the subcutaneous, just at the level here, and this is the humerus, and this is the chest wall in front of the pectoralis major, and this arrow shows there is a lipoma or lipomatous lesion with no enhancement of the godalinum. So you can add with the T1 a godalinum study in order to see the lipoma or the tissue is enhanced or not. What about T2 weighted image? The fluid is bright on T2 image. So it is an easy to remember is that the fluid which contains water, namely chemically called H2O, is bright with a T2. So the number 2 fluid is bright in T2. Likewise, most pathologic process, tumor, infection, injury are often highlighted on T2 images because of their increased fluid content. The fat is less bright, as we see in the table before, and the muscle remains intermediate or iso signal intensity. So proton density images, spin density. These images represent a mixture between T1 and T2 weighting, and within contrast being primarily a function of the number of a proton in each tissue. This sequence also provides a good anatomic detail, but relatively a little overall tissue contrast because of its intermediate weighting. Let's see an example in the spine, cervical spine MRI. You can see the first one in A, the sagittal image of the cervical spine. The CSF here, it shows lower signal intensity in relation to that of the intervertebral disc. You can see this is the spinal cord in the middle, and between it is the CSF. We are concerning the CSF now between T1 and T2. And you can see that the CSF looks like the signal intensity in MRI of T1 looks like that of the disc. In a proton density signal of the C spine or the cervical spine, the fluid looks highly or slightly, sorry, hyper intense to the disc. And the disc also is delineated when it is well hydrated. So you can see this is a proton density image. This is rarely used. And sometimes one of the biggest issues when we see this image, we cannot judge whether this is a T2 or a T1. But here in the third image, you can see a fast spin echo, the T2 sagittal image. You can see here the well highly intense signal intensity of the fluid. And here you have a restriction at the level of C5 and 6 level. And this is the disc prolapse here at the cord, as the arrow show within the cord. The last thing is that the sagittal stir image. This stir image means that when we have applied, very very fat suppression, so much fat suppression, so that in order to do this, the CSF fluid remains hyperintense like that of the T2, but here you can see the fat is highly suppressed as the bone marrow inside each vertebrae is dark now. So what about the frequency, Frequency in selective fat saturation with godalina. Now, you can see the first image here is T1, according to the CSF, and here still we have a T1, but here we can add a T1 also with the godalina. So the T1 here of the lumbar spine, a pathologic burst fracture of the L4 vertebra is evident in a patient with myeloma, a patient known case of myeloma with compression fracture of L1. Now the signal, note that the low signal intensity of edema or sometimes a tumor or both within a fracture vertebra. So in the same one, in B, in the middle one, of the same patient, the lumbar spine with IV contrast, note that the diffuse enhancement of the fractured vertebra with metastatic foci here, these dots are the metastatic foci, are now hard to distinguish from the adjacent marrow. But here, when the IV contrast and fat suppression with a stir, this is here an increase in the signal intensity, which is shown in this picture. Sorry. Okay, so in regarding this stir image, let me check this one. It is fat saturation technique that is result in markedly decreased signal intensity from the fat and strikingly increased signal from fluid and edema. And here is it is an extremely sensitive tool for detecting most types of soft tissue and marrow pathology. We use the stir sequence with most of our musculoskeletal protocols. You can see here the difference between A and B picture. The T2 image of the knee, there is a focal marrow contusion involving the anterior portion of the tibial plateau. Note that this conspicuity of the contusion is relative to the dark suppressed marrow fat. Well, in gradient echo T2, the image of the knee, the contusion is almost disappear and less apparent because of susceptibility effect of the trabecular bone with that of the tibial marrow. So that's why we can use this for this stir. So the stir sequence does not suffer from long image time and limit number of a slice and poor signal that plagued all the conventional stir sequence. We can use a fast spin echo stir. So whenever you see a stir, this means a fast echo. So what about gadolinium? When it is used, whenever there is a mass, like a cyst versus solid, a viable tumor or necrosis, an infection as an abscess versus phlegmon, a disc herniation versus a scar. Now, cystic versus solid, you can see that the T1 image of the wrist where is low. There is a low signal intensity in this mass, which is marked as C along this marker. This is the wrist, okay? And here you can see a fat saturation of T2 coronal image of the wrist, the same, but here we have a T2. So this is a ganglion, looks like a ganglion because we have, or a lipoma, because it is a bright, sorry, this is a ganglion, yeah. And well circumscribed mass. And here you can see that after applying a gadolinium, a cystic nature of the ganglion is confirmed with a peripheral enhancement only and lack of enhancement centrally. The gadolinium usually high signal intensity in T1 and in T1. Yeah. So what you request during the MRI, if you have a pathology in the bone, you have to request a stir, a fast echo study with T2 with fat saturation and T1 also. So when you prescribe an MRI, please give the history, okay? And you have to do a stir within the pathologies in the bone. The pathology in the cartilage, the same, but here you can add a gradient echo, especially when there is a fat, sorry. The pathology in the knee or a meniscus, a spin echo is almost good option, and T2 and T1 will show that. No need for a stir. Labral tear usually at the interarticular gadolinium here is very useful, especially in T1, and the gradient in T2. Tendons and ligament, you have to put a fast T2 with or without fat saturation, and stir. It's very important in order to see the tendons and ligaments as well. The muscle, it's always, as you see, it is a iso signal intensity or intermediate. So that's why stir and T1 is always the same. So what about the bone? Cortical bone is a black in all image sequence. Sorry, what's happening there? Okay, jumpy. All right. Cortical bone is black on all images sequence because protons within the minerals matrix are unable to resonate and produce signal. Within the medullary cavity, fat and hematopoietic marrow are identified. The hematopoietic marrow, which means the medullary canal, is a slight hypointense on fat with T1 and mildly hyperintense on all other sequences, as you see in this picture, with a premature skeletal, with a premature fascial not closed. You can see the difference between T1 and T2 here. So varies according the articular cartilage. Sorry, this is not obvious here with you. Okay, I have to make this one good. Technical issues. All right, so articular cartilage varies according to each sequence. You will see what are the difference between these two images. First of all, you can see that a stir or fat saturation in T2, the cartilage is dark gray, the cartilage of the bone here, dark or gray or black, and easily distinguishable from joint fluid, because making focal defects quite conspicuous conspicuous. Sorry, this word is very difficult. And the cartilage is difficult to separate from the underlying chondral injury or chondral bone. But this distinct is less important than identifying abnormalities of the articular surface. And you can see here, the articular surface defect with bone marrow edema, it can be seen on a stir, while in T1 only, there will be no pathology. This is the same knee. Oh, sorry, there are many admittings. All right, okay, let's go back. So we have a cartilage defect. When you have a cartilage defect, you ask for a stir in order to see it. And this articular defect, the cartilage looks gray, and the defect is here with the bone marrow edema can be shown in a stir because of the fat saturation in T2, while in T1, in the same coronal section, you cannot see it because it cannot be distinguished from that of the synovial fluid. Okay. What about fibrocartilage? The fibrocartilage dark in almost all sequences. So the meniscal tear are best seen in short T2, sorry, this is not TE, TE2 sequence, a spin echo, proton density, which means that between T1 and T2, gradient echo T2 and T1. Useful sequences for the glenoid and acetabular labrum, both T1 and T2, and you can see that a gradient T2 is sufficient without a fast spin, I mean. Let's have an example here in the shoulder. The first image is an axial view with a fat suppression on the left shoulder after interarticular administration of gadolinium solution. The anterior labrum with that of the arrowhead, this one, and posterior labrum of the arrow here are well shown primarily owing the excellent joint distinction and contrast between the gadolinium solution and low signal intensity labral tissue. The fibrocartilage here is normally low signal in all pulse sequences. The second one is a T1 axial of the left shoulder after interarticular administration of diluted gadolinium solution, and best contrast seen between the low signal anterior here and the posterior is here. Posterior labrum, anterior labrum, and posterior labrum. And you can see the labral tissue, how dark it is. Like that of here. Just the gadolinium after dilution. Now, the T2 gradient echo, axial image of the same shoulder. The low signal intensity of the anterior labrum, welcome. Okay, of the, whoa, what happened? Okay, yeah, go back. وصلنا هنا, okay. The anterior labrum and the posterior labrum, as you see, a low signal intensity, both of them, but the lack of the joint distension limits the labral and capsular evaluation overall. Okay. So what about tendons and ligaments? Let's see this one. All right. Okay. So what about these pictures? Look at the tendons and ligaments are generally dark in all sequences, like that of the fibrocartilage. So the apart from the anterior cruciate ligament, we will see that in the knee part of the lecture, in the coming lectures, which shows a striated appearance, owing that the thickness of the orientation of two collagen bundles. Do you know that the ACL has two bundles? The quadriceps and triceps tendon normally have a longitudinal striation as well. Some tendons, such as the posterior tibial tendon, show increased signal near their insertion due to multiple osseous attachments. You can see here in the picture on the left, the above is T1 and below is T2. You can see both of the tendons. The arrow in the black arrow shows that the extensor and the white arrow shows that the flexors of the wrist or of the fingers, as well as here, look at these. These are the extensor, and these are, whoopsie daisy, the flexors. Okay, and you can see here the this part. I will ask one of the candidates if anyone tell me what is this part which is high signal intensity and iso signal intensity in T1.
Nerve.
Can any, yeah,
Median
which
nerve.
nerve? Yeah,
Median
the
nerve.
median nerve. Yes, very good. And what is this? This is the median nerve, and here, this is at the
Palmar.
level of the
Palmar.
carpal tunnel. Yes, it is the palmar.
It's a palmar branch of the median nerve.
Yeah, of course. Thank you very much. So we have some pitfalls during MRI examination. Regarding the ankle joint, this is called a magic ankle. Some of the MRI seniors suggest MRI signal or MRI angle, which refers to as this is an increased signal intensity that may occur in any tissue containing high structural collagen fiber. You know that the collagen fiber, tendon, ligament, meniscus, labrum, all are dark, but you can see these in the arrow. Although the picture is very short or small, you can see the arrow here. There are some signal intensity higher in the posterior tendon ligament. So it depends on the position of the magnetic field. That's why the magic angle effect here in the A, this is normal sagittal view of the ankle. But in the magnetic effect, it is due to orientation of the collagen bundle and occurs in the structure that lies near an angle of 55 degrees. When you use a 55 degrees, you will see this part of only the tendon of the posterior tibial tendon. And you can see all over the tendon is dark. So it is misleading as a tear in the posterior tibial tendon. Okay, so resulting, as we see, an increased signal is seen on the images obtained with the short T1 proton density and most gradient echo sequence, but disappear on the long T2 images. This latter feature allows for differentiation from the true tendon pathology, and other supportive signs include lack of tendon enlargement or peritendinous edema. So please, when you have an ankle, do your request for the ankle MRI, especially for the posterior tibial tendon insufficiency. You have to tell the technician to inclinate the whole plane of the MRI into 55 degrees within that of the tendon. Okay, what about synovium? The synovium is not usually evident unless the pathology is thickened. T1, it shows that after administration of IV gadolinium, without IV gadolinium, the synovium panos has an intermediate signal intensity like that of the muscle that will slightly higher in signal intensity than adjacent joint or muscle. So you have to put a gadolinium better. This slightly higher signal intensity can be detected with careful scrutiny of the images, but much less conspicuous than after the gadolinium. So if you want to have a synovial membrane, like for example, a tumor, a PVNS, or a synovial sarcoma, you usually have to do a gadolinium within the synovium. And you can see here these pictures, the differences between T1 and T2. You can see the whole synovial fluid only without the membrane. Here in this, as you see, the axial synovium is not distinguished from the fluid because both are intermediate signal intensity. Let me go back. Both are intermediate or low signal intensity. And in T2 gradient echo, which is here, higher signal intensity of the knee at the same patient, The synovium is not distinguishable from the joint because both display higher signal intensity. And note, the low signal intensity hemosiderin lining the joint and arrowheads a patient with a hemophilia. But if you have this picture, see, when there is an administration of gadolinium, the thin rim of enhancing synovium, as you see that the synovium is thickened, and this is the synovial fluid, is low signal intensity. So taking a home message, each anatomic site contains multiple different structures within the volume being imaged. For example, tendon, cartilage, bone, muscle, spinal cord. And it is necessary to use protocols that adequately shows all these varied structure. And I usually do, when taking an MRI, I request an MRI with the technician. Please sit with the technician and tell him if you have an inclination for 55 degrees with the ankle, or if you have an ACL, and we will see that in the coming lectures with the knee, how to take the image. We have to know because most of the technician doesn't, and don't, sorry. Technicians don't, yeah, grammar. And most of our colleagues in the X-ray specialist or MRI specialist, they know how to do it, but they don't use it with the technicians. The second thing is that a pulse sequence and imaging planes must be selected carefully to show these structures optimally in the relatively short time. And the last thing is that the clinical indication and brief history of a patient for obtaining MRI examination further help to determine which pulse sequence and image planes should be selected. So please, when you don't know how to take the MRI, you can only give a brief history for the patient in order to make a referral case or referral notes into your colleague with the MRI. Thank you very much for listening. And let's have some questions if you have it, if you want to share ideas. The mic is yours.
Dr. Sinan?
Yes, Dr. Mohammed.
Any special sequence for articular cartilage?
Yeah, the articular cartilage, we see that the gadolinium with T2 and gadolinium, better.
Just gadolinium.
Yeah, with T2 أفضل.
With T2.
لأنه إحنا قلنا articular cartilage. Let me see this one. A fiber cartilage. Okay. And this is the articular cartilage. You can see a stir with gadolinium or, stir or T2. Stir is better, sorry, not gadolinium. If you have a defect or a chondral injury, like this one, you can see this picture.
I think I missed this slide.
Yeah, okay.
الgadolinium prefer to be IV or intra-articular?
Yeah, IV, systemic.
Systemic, okay.
يعني لحد هسه ما شفنا في مكان انه ينطوا intra-articular, but it's better to be a systemic because every time they do T1 or T2 image, they give the IV gadolinium first and then they do the contrast.
وبالنسبه للانترا يعني للام ار اي للانترا ارتيكولار يفيد بس باللابرال تير والاستابيلار يعني الجلينويد لابرام او استابيلار لابرام لو الاي بي همين كافي.
I don't think so. The local gadolinium will affect that because they need an enhancement within the arterioles. هي الفكرة إنه شنو؟ إحنا عندنا يعني مجموعة من arterioles there. So when you give a systemic gadolinium and then you wait for I think half hour or something like that, and then there will be an enhancement within the tissue that you want to do an MRI. So that's why a gradient echo with fat suppression and then with the gadolinium study, we'll see that how the picture will be elaborated. I think this one. No, let me see. Okay. This one here. This is a stair. Okay, now you can see here, this one, yeah, this spine. You can see between, Dr. Mohammed, are you with me?
There we are.
Okay, you can see this is the T1 and this is the T2 and this is the after administration of IV contrast. And look at with the fat suppression, of course. And here you can see how the lesion and the intramedullary foci of metastatic foci are well seen. Sorry.
دكتور سنان بالنسبه للمالتيبل ارو هاي مالتيبل سايت مال ميتاستاسيس posterior
yeah this one and
حتى
this one
بالposterior element.
بس هو يعني بالضبط هاي المالتيبل اروز. بس اذا تشوف هنا هذه يعني المكان مال شو اسمه الكومبريشن. زين. And that's what you mean by the gadolinium, yes. Okay. Okay, let's see the chat. If you have a question, thank you. Okay. So, if you have a question, you can write it or share more ideas about the MRI. These are some basic principles, some of them, not all of them, in order to make a full image of the MRI in regards of musculoskeletal. So the next lecture, the next episode will be about the knee regarding the MRI, and I will separate it into two separated lectures, and then another two separated for the spine.
اوكي عاشت ايدك دكتور سنان.
Thank you very much.
نفس الموعد احد الجاي؟
اوكي الاحد الساعة 9 ان شاء الله.
ان شاء الله.
Thank you very much and I hope بالنسبة للناس يمكن اجوا later, this one has been recorded and I will upload it with the YouTube. All right, I will give the YouTube link here.
عم سنان عاشت ايدك.
ويدك حبيبي، شكرا.
الله يحفظك. بالنسبه للسيكونس واستخدام الكونتراست، هذا اور جوب لو الراديولوجيست هو اللي يحدد.
No, this is a radiologist job actually, but you have to request it. أنا حطيت هنا. وينك. This table، يعني هاي اختصرت لك اياه table هذا. When you have any pathology, you can request these sequences as you need it. All right. Okay. Just to put it in your mind. Okay. I will attach the link here. Where is the chat? Okay, to everyone. Okay, you can see the YouTube. You can have subscribe or just follow, just like, and you will see these videos are uploaded later. 1 hour تقريبا، يعني almost 1 hour. Okay, so see you next week in the same date. I hope that everyone will come late, will come earlier in order to see the full lecture, or if you miss it, you can see it in the YouTube. Have a nice day and good luck. Thank you very much and goodbye.
عاشت ايدك عيني دكتور سنان.
حبيبي ممنون.
شكرا جزيلا دكتور سنان.